Hello everyone, this is Dr. Pratpal Singh, an MD from CMC Ludhiana, and I'm an MD of Pharmacology. And uh, I had started with the session on drug use in special population, where I have been talking about drug use in pregnancy lactation, drug use in pediatric uh, population, and now today I'll be talking about drug use in geriatric population. And when we talk about the geriatric pharmacology, this comes under the new curriculum of CBME 2019 under the competency PH 1.56, which says describe the basic aspects of pediatric and geriatric pharmacotherapy. So what I'll be doing is I'll be talking about some cardinal points for geriatric pharmacotherapy. And I hope I'll be able to give you some insight into geriatric pharmacology, they are also known as baby boomers and beyond. So let's talk about some pharmacokinetic changes that occur when we talk about the geriatric population. The first thing is that there is a decrease in total body water and an increase in total body fat. So that can affect the volume of distribution. So increase in body fat means that there would be increased toxicity of certain drugs that are highly lipid soluble, and decrease in body fat would mean that we have to take care of certain water soluble drugs. So let's talk about what happens exactly. We have certain water soluble drugs such as lithium, aminoglycosides, alcohol, digoxin. Their serum level goes up because of decreased volume of distribution. And when talk about fat soluble drugs such as diazepam, thiopental, and trazodone, the half life is increased because the body fat is increased. Regarding the absorption is not majorly impacted by aging. There is a variable change in the first pass metabolism due to variable decline in hepatic blood flow. So elders may have less first pass effect than younger patients, but this is again extremely difficult to predict. That means there is all possibility because of less high pass first pass metabolism, there is all possibility of increased toxicity of the drug. Apart from this, when we talk about the oxidative metabolism through cytochrome P450, now this particular system decreases with aging, resulting in decreased clearance of the drug, and the hepatic blood flow becomes extremely variable. Talking about the excretion and elimination, the GFR generally declines with aging, but it is extremely variable. To give it, let's say there's a rule of 30, there are 30% of the population would have little change, 30% of the population would have a moderate decrease, and 30% would have a severe decrease. So we need to monitor the renal function, and this, when we talk about the renal function, serum creatinine would be an unreliable marker to go ahead for clearance of a drug. So what do we need to do? We need to take care of the creatinine clearance in an elderly. Now we come to the creatinine clearance, which is calculated by the Cockcroft-Gault equation, which talks about the creatinine clearance. Now in the creatinine clearance, it is a formula which says 140 minus age, this is depicted in years, multiplied by weight, which is depicted in kilograms, upon the serum creatinine level, which is and multiplied by 72. This is in cases of male, and if supposedly it is a female, then it is multiplied. This whole particular equation is multiplied by 0.85 for females. You may overestimate creatinine clearance if the elderly is frail, and obviously it is a very useful equation, but obviously everything has its uses and limitations. Apart from pharmacokinetic, there are pharmacodynamic variations also. So let's see what are the effects that could be increased. First, let's talk about alcohol. Alcohol could increase the drowsiness and lateral sway in older people as compared to the younger lot, which has the same serum level. Similarly, the effects of fentanyl, diazepam, morphine, theophylline could increase. And then there are some drugs whose effect could decrease, such as a decrease in heart rate response when beta blockers is conventionally given to an elderly patient as compared to a young adult. Apart from that, there are another things that are there, that is false. Now, biggest risk drugs are those drugs that are long-acting benzodiazepines and other sedatives which produce a lot of hangover. So late night hangover could lead to a high incidence of fall. SSRIs and TCAs have been associated with increased risk of fall. Beta blockers has not been associated as per published literature, and there is a mild increase in fall risk from other drugs such as diuretics, arrhythmics, and digoxins. So when we talk about elderly as a general, as a whole, when we talk about elderly population, one of the major things that you need to keep in mind is polypharmacy. Most of the elderlies do tend to take 4 drugs, 5 drugs, or maybe more than that. And the higher the number of drugs, there's increased incidence of fall, there's increased comorbidities in these patients, and there is increased drug interaction, increased electrolyte imbalances, and there is always an increased incidences of adverse effects in elderly population as compared to younger lot, because the elderly take more medication than any other age group. The pharmacokinetics and pharmacodynamics are already altered. As I have told you, the adverse drug reactions are quite common. I already told you about this. And with the increase in number of drugs, the risk goes up. Apart from this, the another problem is the non-prescription and herbal therapies are quite common. So what is the best thing to do? Best thing is you should have appropriate care and a common sense. You will be able to perform much better for a geriatric age group. So that's all from my side, and I hope I have been able to give you some insight into the usage of drugs in the geriatric population. If you have any queries or questions, get back to me. You can get it. You could write down on my chat box, and I'll get back to you. So have a happy day, have a great day, and a happy learning. Thank you so much for your patience.